Yeah.
Beautiful. Thank you. I just paused that while I was getting that meeting settings all set up.
Awesome.
Super.
Sorry. There we go. That's better. Thank you. Brilliant. No, I'm just kidding.
So for relative polycythemia, meaning your red blood cells are only elevated relative to your plasma volume, the biggest cause, like we just said, of that is going to be dehydration. What else are we going to do for our patient on blood work or physical exam to help to confirm that?
Like your TP will be elevated too in some instances of dehydration.
Yeah, amazing. So we're going to have elevated PCV, elevated TP typically, and potential findings on physical exam of dehydration. For the other, that transient cause that we mentioned for splenic contraction, it's going to be transient and it's going to be generally really mild as well. They're not going to be, PCV of 80 and clinical for it. It's going to be our relative causes. And then approach to absolute causes. So say we've definitively excluded relative, we don't have a dehydrated patient, it's repeatable. How are we going to further assess our absolute causes? Does anyone have a kind of approach to that they want?
Like appropriate or inappropriate, is how I think of it.
Mm-hmm. Do you want to explain what you mean by that?
Like if the dog lives at altitude or has a shunt, then it's an appropriate increase. It's the body appropriately responding to hypoxemia.
Yeah.
Versus inappropriate is like a tumor pumping out EPO.
Yeah. Amazing. And just to go one step back, we'll explore that area a bit more. That's going to encompass our EPO dependent causes of erythrocytosis. What's the other group over here that's apart from those ones?
They call it EPO independent.
Yeah, perfect. So we're going to have primary EPO independent. Doesn't matter what on earth the EPO's doing. We've just got pumping out of red blood cells, and then EPO dependent. And like Simone says, we can separate that into, is it an appropriate response or inappropriate response? Clinically, just to recap, I know we all know, but EPO, it's produced by your renal interstitial fibroblasts. They're specialized to detect hypoxia, produce erythropoietin, which is going to directly act on your bone marrow and stimulate new red blood cell production. So Simone, you mentioned a good one, like altitude, which isn't super relevant for us smallies vets. I don't think I've ever seen it, but I know cows and things get it, I think. In terms of clinically relevant, EPO dependent, so we've got increased EPO production in the body, but that's an appropriate physiological response. If we go down that algorithm, has anyone got any idea about clinical cases we might see that could cause that?
Can I tell us?
Dependent.
We could.
Yeah, like an appropriate polycythemia.
Oh, appropriate polycythemia. So like if you have, if you have cardiac disease, so some sort of like right to left shunting, if you have renal disease, and then even respiratory, because like hypoxemia comes from respiratory disease too, or can come from respiratory disease.
Yeah, absolutely. I think a good example of that is when you see really bad Boas dogs and they sometimes have a higher PCV and they're probably just walking around like a bit hypoxic and their body is appropriately compensating for that by producing more EPO and they have these high PCVs. So yeah, absolutely pulmonary disease, like you said, Pooja, it'd have to be quite severe, but for sure. We had an interesting case recently, actually, of a right to left shunt that Anna had that had an erythrocytosis. So that's going to be really appropriate because does anyone want to do you want to expand on that, Pooja, or I can if you'd like about right to left shunting, just it's on our radar. It's uncommon, but
I'll listen to what you said because you can relate it to the case you, so I'm interested in the presentation of your case.
Yeah, so if we think about if you normally have, I say normally, if you that case in particular was a reverse PDA. So if we think about a cardiac disease, so this is going to be quite a severe cardiac disease. If you have a shunt, which is, for example, a PDA, your blood is always going to typically shunt from the high pressure to the low pressure. So you're typically going to get a shunt from your left of oxygenated blood into the right. Then that's going to go into the pulmonary circulation and round like that. But if you have a situation where the shunt is now going from the right, so what was the low pressure side into the left, which is that case in particular was due to pulmonary hypertension. So now we've got, instead of the shunt going from left to right down its pressure gradient, we've got high pressure in the pulmonary system that the shunt can reverse. When we have a right to left shunt, we've now got the deoxygenated blood from the right side shunting to the left side, and now we've got that mixed population of blood pumping into systemic circulation, leading to chronic hypoxia. So we're only really going to see that potentially, Anna, correct me if I'm wrong, but with that, something like a PDA with pulmonary hypertension, a tetralogy of Fallot could cause it, and then really weird things like a VSD if you've also got severe fibrosis.
Yeah, so in like 30% of congenital cardiac abnormalities, there's more than one cardiac abnormality. So having pulmonic stenosis and a VSD is not actually, like, all of these things are uncommon, but if you've got one of them, then you're much more likely to have another one as well. And this case, can I expand on this case? Do I have time? All right. I love this case. It was, so an 11-year-old Jack Russell came in to the vet. It was the first time that this owner had brought it into this vet. So it had been rehomed 2 years before on heart meds. So it was already on pimabentan. It had presented to another vet in congestive heart failure, diagnosed on X-ray by cardiomegaly a year before, and started on frusemide. And at that time had a 5 out of 6 murmur audible. So we've got a dog with documented cardiomegaly, 5 out of 6 murmur, and it's a 10-year-old dog, right? Like, at this point, it's an old dog. And they started on frusemide and it responded well. So we've then got like kind of proof of concept, like this dog was in congestive heart failure, pulmonary edema, cardiomegaly, all of that stuff. So it looked like a slam dunk degenerative mitral valve disease, but it had never had an echo. Was rehomed to the new owner, and the previous owner had died, so there was no handover history or anything. It was just kind of handed over with these meds. And like the new vet then went back and got the old history, but the owner had no idea what was going on with it. And then the dog came in like going cyanotic every time it was like exerting itself or stressed or excited, and occasionally having little syncopal episodes with the new owner. And the new owner's like, she's always done it. Like, I just didn't really think about it. And they assumed she was in congestive heart failure again, up to frusemide. That didn't work. So they got me in to do an echo, and I listened and I was like, there's no murmur in this dog. Like, no murmur. I can't hear anything at all. And it's clearly documented throughout the history. There was like a grade 3, a grade 4, a grade 5 murmur in this dog, so kind of progressive murmur. And I couldn't hear it. My ears are pretty bad, but they're not that bad. I can usually hear a 4. So I did this echo, and this dog has such severe pulmonic stenosis and pulmonary arterial hypoplasia. Like, the pulmonary artery was non-existent. So you can normally see that coming out of the heart really well. So then we've got the right side of the heart that's operating under much higher pressure than usual. And then I was like, well, I actually can't see any other abnormalities in this heart. And what had happened, sorry, I shouldn't say that. I couldn't see a shunt. Like, I couldn't see the blood flowing right to left or left to right. And what had happened is that the right side of the heart had become so hypertrophied and pressure overloaded that it was sitting at equilibrium with the left side. So this dog had a massive VSD, but the blood was just all like flowing around in it. So that left and right blood were just getting merged, and then deoxygenated blood's going out into circulation. And obviously when I'm looking at the dog, it's sedated, so it's not actually excited. But as soon as the dog gets excited, the pressure on the right side exceeds the pressure on the left side, and you get more of that deoxygenated blood going out into circulation. So this is the oldest dog in the world with a tetralogy. Maybe not in the world. I didn't actually do a full literature search, but I spoke to a cardiologist about it. I was like, it can't be really what's happening. But it had a tetralogy, so it had pulmonary stenosis and hypertension, a VSD, and a shift in the aortic root. Anyway, this dog on blood test had a PCV of 72. So it's really chronically got hypoxic blood running through its circulation to those renal fibroblasts. And Helen said, we all know this, but I actually didn't know that. So thank you very much. The EPO is produced in the renal fibroblasts. Is that what you said? Anyway, that's the end of my story.
That's a very cool case. Thank you, Shanna, sharing it.
Very
Really
cool.
cool.
Yeah.
The thing is, like, if the animal is alive for 2 years and is diagnosed on CHF, that itself is a flag, right? In hindsight, you can look back and say that's not right because CHF, like your mean survival, is not 2 years. So once they're in clinical CHF. So, but that's only in hindsight. At the time, you wouldn't know.
Yeah, although it's not uncommon. Yes, exactly. And it's not actually uncommon for dogs to do surprisingly well on pivabendin sometimes. Those old dogs and you're like, gosh, they've like renal heart failure a year ago and they've just sailed along since then. So yeah, I would say like we see that because we do the repeat echoes and stuff. We're often sort of saying, yep, stage C, pulmonary edema and stuff, chuck them on medications. And then a year later, I'm echoing them going, oh, it's better than it did when I first saw it.
Yeah, that's true. And I think it's a nice case to say when we're thinking about those cases of appropriately increased EPO. So their elevated PC is an appropriate physiological response to hypoxia. There should, in theory, be flags on our physical exam. So we're going to get so much out of our history, our physical exam, and our PCV-TP, even before we've done any expensive tests, to then help to guide our diagnostic pathway. Because if we're going to have cardiac disease or pulmonary disease that's significant enough to cause that, hopefully there's a flag early, or high altitude. Hopefully we'd know that from the history. There's one other thing that can cause it. It's really uncommon, but like in an emergency setting.
Methemoglobinemia.
Yeah. So carbon monoxide poisoning that's going to bind to your heme, and then that has a much higher affinity for the heme than oxygen. So it's going to decrease the oxygen carrying capacity. Cool. Shall we move on to EPO inappropriate, because they're the more fun ones? So EPO inappropriate, in what circumstances could we have inappropriate EPO production in the body?
Renal neoplasia.
Yay, the most common. Yeah. Which renal neoplasia, sorry, does that mean to ask?
Sarcoma, usually.
Yeah, so any of your renal cells, so renal carcinoma is probably the most common one that we see. But you get other renal tumors like nephroblastomas, fibrosarcomas. I think even renal lymphoma can do it, can it, Anna?
I have to say, I read about this and I've always got it on my list, but I've never seen erythrocytosis associated with a renal neoplasia.
Yeah,
in all my years. Yeah.
Fun. Well, I think I think it's nice to have on the radar. Another interesting one. Does anyone know any others?
Endocrine diseases can do it. So like hyposomatotropism can do it because that can cause megaly everywhere.
Yeah.
Organomegaly everywhere.
Yeah. It's a really good one. Yep.
Hyper T maybe? Hyper T can do it in cats.
Yep. Do endocrinopathies. Yep. Any other?
I don't know if renal, when we talk about renal disease, do infections do it? Like said pylo or things like that, like actual in reality, not just theory. Has anybody seen it with pyelonephritis ever?
I don't know actually. Anna, do you know?
My instinct would be, I've never seen it, and I've never made the link of reading about it with pyelonephritis, but my instinct would be actually you've got reduced renal function with pyelonephritis and actually probably reduced CPO as a result rather than hypertrophy or hyperactivity of those cells.
Yeah.
But that would I would be much more likely to think we get an anemia of chronic inflammatory disease or decreased EPO or combination of those with a chronic pyelo.
In the textbook, Ed and Judd, it's got 3 case reports of pyelonephritis causing polycythemia.
Oh, there we go.
Yeah, that's what I had. Like I've read it somewhere. It may have been Nightingale. I can't remember.
There we go. That's very interesting. That's very interesting. We'll have to look at the yeah, because you wouldn't think it could increase function. Interesting. I would have thought they'd be dehydrated because they've got pyelonephritis, but obviously not. Yeah, interesting. Does anyone know or seen any other types of tumors that are associated with EPO production? I'm not saying that it's common, but being reported. So the 2 other ones are hepatocellular carcinomas and leiomyosarcomas. So of most commonly seen of like smooth muscle tumors, like of the GIT, for example, which I thought was quite cool to have on your radar. And I guess the reason I think that's a good thing to keep aware is it kind of helps our diagnostic pathway of once we've done our history, physical exam, PCV, TP, we're going to either kind of be going down, we need some imaging. We're probably either be going down the echo and the thoracic radiograph route or the abdominal ultrasound route to rule out neoplasia. I think would be a very fair diagnostic pathway. If you agree, Anna.
The renal cases that you guys have seen, has there always been azotemia associated with the, or can you have it in a non-azotemic animal?
I've definitely seen renal tumours in non-azotemic animals. Do you agree, Anna?
Do you mean in patients with renal tumours as a cause of erythrocytosis or
Yes, yes.
azotemia with erythrocytosis? Yeah, because you can take out a kidney without getting an azotemia. So the tumour could occupy the entire renal tissue on one side without necessarily causing azotemia as long as the other kidney is still functioning.
Yeah. I just want to share my screen, but my thingy's just all corrupted. So I might have to, I think it's going to work, but we might just have to not have a picky, which is a bit annoying. I'm just going to share my screen for something.
What was the presentation of your case, Helen? The one that you were saying you saw this interesting. Like, what was the presentation?
I'm going to show you.
It came in, essentially it came in for routine vaccinations, but the owner was like, but it was blue on assessment and like in respiratory distress. And the owner was like, oh yes, faints a lot. Like, yeah, that's just him. He's always done it. So because it was a new owner, that's kind of what was handed over to her. And she's like, 11.
Oh, it's the same dog.
Oh, no,
which one?
The one that Helen was talking about or wanted to talk about. Your dog.
I'm going to talk about it now.
Oh, okay. Sure.
Oh, good.
Can you guys see this?
Yes.
Okay, great. Okay, so I'm just going to move you guys over here. This is kind of what we've just spoken about, but I just think it's a nice visual for those causes that we just touched on. Is it relative? We're going to have markers of dehydration, elevated total protein, make sure is really going to be supportive of relative, and we're going to make sure that it's repeatable as well. And then absolute, like we've just covered, splitting them into primary, EPO independent, which we haven't spoken about yet, but we will, and secondary EPO dependent. And then as Simone said, further into an appropriate EPO dependent response, so to hypoxia, or inappropriate, which most commonly is a neoplasm pumping out EPO. Does anyone want to, just before I talk about my case, does anyone quickly want to talk about primary polycythemia, or what we mean by that? It's really rare. I don't really know if I've seen it. I'm
Yeah,
sure
I've
Anna.
never seen it, but like just polycythemia when you're just pumping out more
Yeah.
RBCs. Like it's a tumor or myeloproliferative disease.
Yeah.
Yeah.
Absolutely.
So it falls under the classification of a myeloproliferative disorder rather than a neoplastic disorder, but it's kind of a spectrum. But yeah, I've definitely seen it. I think it's less rare than like an EPO secreting renal tumor, for example.
Sure. Yeah, that's a good point.
We've got a few cases that we bleed intermittently.
Mm.
And essentially, the reason I want to talk about that is the case I'm going to talk about. It's really going to be a diagnosis of exclusion or bone marrow biopsy for primary, so polycythemia vera. And the case I'm going to talk about could well have it. Unfortunately, the owner, actually, this dog, we'll just talk about the case, shall we? Because it's more fun. Because I'm kind of assuming it's one thing, but it could well be primary, and we'll talk about the kind of how you guys would approach it. So 9-year-old male-neutered golden retriever, 2-month history of lethargy, exercise intolerance, PUPD, and sometimes the owner felt like there was mentation changes, so like a little bit dull or a little bit off. On physical exam, really red injected mucous membranes, grade 3 heart murmur, and a heart rate of 100. On baseline bloods, we've got a hematocrit of 72, rest of CBC normal, and a mild ALT elevation. What does anyone want to say what else they might like to do, or what you'd like to do next? Or I can let you know what we did. So his case is quite consistent with it being an absolute, but we don't know that yet. He could well be dehydrated. I've said that the rest of his biochemistry is normal, so his total protein was well within normal limits, and he didn't have any markers of dehydration on physical exam, and he didn't seem a particularly stressed dog coming into the clinic that could cause that splenic contraction. So we could repeat it to make sure, and we could rehydrate him to make sure, although we're not convinced that he's dehydrated. He hasn't been off food or water at all. And if we're happy that he's absolute, we can go down that same pathway. So is this inappropriate, appropriate, and above that, primary and secondary? As you said, looking for primary, so polycythemia vera is essentially a diagnosis of exclusion. So we're going to exclude our secondary causes before giving him primary polycythemia vera. So those secondary causes, he doesn't live at altitude. We're happy he doesn't have carbon monoxide poisoning, which we're going to get from the history. And so we could go down the route of an echo because of that murmur. We don't really have evidence of respiratory disease. So this patient didn't have an echo or thoracic radiographs. We went to abdominal ultrasound. And this is the bit that's missing. I don't know why this isn't working. It's supposed to be a little video in here. This is a video of a big, juicy liver tumor in him.
Can I ask a question?
Please.
What made you go down abdominal ultrasound as opposed to, say, doing cardiac workup first? Like, because like when I'm just looking at the first slide, I'm in my head thinking, okay, which way to go? Either or would be.
I think either's totally appropriate.
Yeah.
If you agree, Anna. Like, I think I probably own a budget and access to those things.
Yeah, it's mostly access, isn't it? Like people are more likely to have abdo ultrasound in-house, but to detect a right to left shunting abnormality in a heart, you probably need a cardiologist.
Or an Anna, yeah.
Definitely tapped in the cardiologist for that last case.
The only reason I asked is because if you guys saw something that made you lean towards one that I wasn't seeing, that's why I asked.
No. And to be honest, I think this would be a good patient for a dual cavity, like to actually just scan both at the same time. Interestingly though, that murmur could just be from increased blood viscosity. So it could be due to changes in alteration with a hematocrit that high. Because the blood viscosity, I guess this would be a good time to just pause and say, which we should have spoken about at the start, why do we even care if they've got a high PCV? Is it something that we can just ignore for him? Like, do we know that that's that's an important thing to chase, or could we just ignore it for his quality of life?
I think it's important to chase because hyperviscosity will cause other problems, and like they can become hypercoagulable, they can throw clots, embola, thrombus, whatever.
Yeah, absolutely. Yeah, absolutely. So I think that's something I should have touched on at the start. Sorry, that it is an important thing to chase because it does affect their quality of life. It does cause morbidity. So it does cause these vague signs that we've got here: lethargy, exercise intolerance, mentation changes, and that change to blood viscosity, like Pooja mentioned, that can impact renal function, which is maybe why they get PUPD. I don't know if anyone definitively knows. Correct me if I'm wrong, Anna, but I think it's thought to be changes to blood viscosity and changes to blood delivery to the kidneys.
The PUPD?
Yeah.
It's actually central, I think. My understanding was that it was hyperviscosity decreases blood flow to the hypothalamus and increases decreases ADH production, which then means that they're urinating more and then they have to drink more.
Interesting.
Yeah, that was my understanding.
That's interesting. So hyperviscosity definitely can change blood flow, and it can cause mentation changes, neurological changes, and even blindness and seizures. I mean, I guess it would have to be severe for that, but it's definitely reported is an important thing to chase.
I've definitely seen that actually. Dog in status due to erythrocytosis.
Crazy. How high was it? How was his PCV?
In the 70s.
Easier.
Yeah.
Interesting. So the reason I wanted to talk about this case is this is supposed to be a nice big juicy video of what was diagnosed as a hepatocellular carcinoma. It was an interesting discussion with the vet that was managing this case, because we were discussing in the short term, he was quite clinical for that high PCV, which was repeatable and could be documented over the course of multiple blood tests. So in the short term, like Simone was saying, a phlebotomy is a really appropriate thing if you're worried about the patient in the short term. Simone, do you want to touch on how you guys approach doing that? She might be busy. There's lots of good resources online, but essentially, like, you're draining them to be a blood donor. So really light sedation. Often, if you've got like a big happy golden retriever, you might only need to give them a little bit of butorphanol, and exactly like you would care for a blood donor, replacing them with IV crystalloids as you're bleeding them. And there's lots of guidelines for how much you can take, essentially to try and bring that PCV down into a normal range without causing hypotension or circulatory collapse, of course. And you can repeat that as needed. It's obviously going to be temporary, but it might be good both if they're awaiting surgery for something like a renal tumor, leiomyosarcoma, or hepatocellular carcinoma, or just palliatively. The interesting thing with him is we don't really know if that's definitively going to be from the hepatocellular carcinoma, or if he's also got a myeloproliferative disorder of primary polycythemia and got polycythemia vera. I guess for this patient, I'm sure you've all seen hepatocellular carcinomas in animals that are very low grade. They kind of hang out there and don't cause any issues and never get surgically removed. This was a 9-year-old dog that is going for surgery. So essentially the plan is to kind of see if it resolves after surgery, and if not, we might be left with primary. This would be a good patient to also take a bone marrow biopsy on, in conversation with the owner, if they wanted to do everything at once or stage, and then go down options. There's chemotherapy options that you can use for primary polycythemia vera and repeat phlebotomies. So essentially palliating the clinical signs. Yeah, I thought he was interesting.
If this owner is keen, would you do the surgery and the bone marrow biopsy at the same time? Is there any contraindication to doing both together in the same sort of anesthetic, or?
I don't really think so. I don't know if Anna would have an opinion on that.
I definitely do both. I think bone marrow is so minimally invasive. We don't do enough of it.
And like he's a big dog, you could get a decent sample and
Easy peasy. Yeah, it's like we usually do it under domicile most of the time. It's really like non-invasive.
Yeah. And then one more question. Because I've never really had a case personally, like, do you guys use hydroxyurea? Like, when do you choose phlebotomy over hydroxyurea?
or both, because if you've got a patient that's, what I would say to that would be, if I had a patient that I was worried about, like Anna mentioned one that was seizing, it's got neurological signs, altered mentation, I would stabilize it, at least initially with. I'm sure, I don't know what Anna, your opinion is on that, on a combination.
Yeah. It depends how acutely unwell they are, I reckon. So phlebotomy is a nice get out of trouble option. And it depends a little bit on the owner as well. If they've got like if they're nervous about using chemo drugs and stuff like that, then I'll avoid hydroxyurea. But in my hands, I've actually found it's very well tolerated. Sorry about that.
Great. Yeah. So I thought it was an interesting one where he could have, his polycythemia could be from both or one or the other. Luckily they're going to go for surgery anyway. His tumor, which I want to show you, was really was quite cystic, so it's going to be at risk of rupture, at risk of getting abscessated, which we see with some of those massive HCCs. So he's 9, but he's not that old, so it's a good idea to remove it anyway. And then hopefully we'll know what his PCV does afterwards. Does that make sense, that kind of approach to polycythemia?
Yeah. How soon, if it's going to make a difference, like, do you have some timeline in your head? Like, when are you expecting it to make a difference? Like, would it be, because this is chronic, like, do you expect resolution sort of soon after surgery? Are you giving it a month to sort of settle down?
Yeah, I guess you'd need to wait for the canine red blood cells to die off. So yeah,
So 120 days.
I think it would be reasonable to wait, to give it a bit of time. Again, depending on how clinical.
Yeah.
It would be interesting to see what sort of, like after the phlebotomy, what sort of regeneration you get. Well, so if you've got PCV down to 55, for example, then you take the tumor out and you take out the source of EPO, then maybe you wouldn't get regeneration. Maybe it would just stay at full start. I don't know. But EPO doesn't actually stay around for that long. So once you've taken out the source of it, you should get regeneration beyond about 7 days.
Yeah, that's a good point. Yeah, nice. Cool. Any questions about this everything we discussed about polycythemia? No. Everyone want to see one now?
Yes.
They're all just going to be dehydrated, but
See everything.
And I think Anna and I spoke about this, that we probably do see a lot that we're like, oh, they're probably dehydrated, and actually maybe more of them do have underlying pathology, potentially. Okay, cool. I'm just going to stop sharing my screen for a sec. So probably what everyone's more excited about is anemia, and I know there's so many resources and webinars and great stuff on anemia, so we can kind of do this in any way that we want, or kind of focus or go down rabbit holes that are interesting to people. Approach to anemia. Does anyone have a algorithm? I'm sure we all use a similar structure in their head of see a patient, you take a PCV and it's anemic. What the first really initial thoughts are of how we should approach that? And we can even keep it as simple as what other things on our CBC or blood work are we going to look at to start with?
So the first thing I look at is, again, to confirm firstly, and then also see if there's regeneration, any evidence of regeneration. But bearing in mind that if it's the first time point, because regeneration can take 3 to 5 days, like I wouldn't call it non-regenerative on the first time, like just on the first time, because I don't know.
Yeah, absolutely. And how do you want to look for regeneration?
Reticulocytosis, like you look for that, and then always like I'm always making smears for everything. So look at the smear as well to see if am I seeing polychromasia,
Yeah,
cytosis.
yeah, amazing. I think erythrocytosis is a really important one. My laptop's going crazy and everything just keeps corrupting that I want to show you. I want to show you, but I can't get it back up. Erythrocytosis. So the in-house analyzers, not all of them have, excuse me, erythrocytosis. Reticular.
Yeah, I thought you were saying you were meaning that.
Getting distracted. I'm just going to leave it. I'll just Google it and show you guys. Obviously, a lot of the in-house analyzers do, but they don't all. So external, I feel like we say this over and over again with the Vets North, external CBCs are so helpful to get that reticulocyte count if you don't have it. You can obviously look at a smear in-house or a pathologist smear for reticulocytes. And the little dot plots, if you've got an in-house IDEX machine, does anyone look at that dot chart? Or just
I don't.
Yeah, amazing. Do you want to elaborate on how we can confirm that there's reticulocytes there on a CBC dot count?
Like on the side, you'll see like a cloud, excessive numbers. Like that's how I essentially
I want to show you, but my little presentations have decided to corrupt, so it's not showing any images. So I'm actually just going to see if I can just show you one on IDEX, because I think this is quite cool. So can you guys see this?
Yes.
I know we kind of ignore this. I feel like I always used to until I learned how to get them. So, okay. Here, can you see my cursor when I'm showing? Okay. So here we've got blue are the little platelets down the bottom, which is really nice when you want to confirm a thrombocytopenia. Red, we've got red blood cells coming up here, and then the pink that's circled in this nice example are our reticulocytes. And the fluorescence just means it's the dye is binding to the nuclear material, which is still present within the reticulocyte. So looking at your dot plot as well as your reticulocyte count, especially if you've got the in-house ProCyte, which lots of clinics do, is a really nice way to just confirm, yeah, there's reticulocytes there. So we're going to we're going to classify the anemia as regenerative or pre-regenerative or non-regenerative with a reticulocyte count. What else on our red blood cell indices could we look at?
MCV and MCHD.
And what we're going to look at on them?
Whether it's microcytic or hypochromic, or which would be an indication of anisocytosis or spherocytosis.
Yeah, absolutely. So size, so micro or macrocytic. If we have a regenerative anemia, what would we typically expect with what change to size?
Be bigger.
Yeah. And in what conditions do we sometimes get microcytic?
Iron deficiency.
Yeah, perfect. Do you know why?
It's because the iron is the signal for them to stop dividing, so they just keep dividing.
Yeah, amazing. Yeah. So it could be microcytic or macrocytic. And then you mentioned hypochromic. So we kind of classify them as hypo or normo. In what conditions would we see that hypochromasia?
Iron deficiency again.
Yeah, perfect. Yeah, deficiency.
GI bleeds as well, and I think also like looking at retic HB, because that will go down sooner than MCV or MC.
Yeah, absolutely. That's a really good one to be aware of. Just to double click on the iron deficiency, I feel like we see those anemias not a lot, but fairly often, because we're not necessarily seeing like an absolute lack of iron, but like a functional iron deficiency. So patients with chronic inflammatory disease, which is going to upregulate storage of iron. and reduce your macrophages releasing it. I think that's a common thing that we'll see in those kind of grumbling along, those cats that are like have this grumbling little chronic anemia, and can be hard to differentiate from a chronic blood loss iron deficiency anemia, like you mentioned, Pooja, like chronic GI being the most common, or even chronic urinary, like cats with subs can get it, and they're just constantly losing their blood. Yeah. Great. So we've determined it's repeatable. We've determined it's regenerative or poorly regenerative. Should we do regenerative first because it's the fun one? So regenerative, we're going to have increased reticulocyte count. We might have a macrocytic anemia. What's going to be our approach to knowing whether within regenerative, we're going to have two big categories of blood loss, of hemorrhage and hemolysis. What's going to help us to go down each tree?
Get a low total protein with hemorrhage.
Yeah.
And hemolysis, you might get a hyperbilirubinemia.
Yeah.
And you might see it on the smear as well.
Absolutely. So we're going to do a TP. How low do you think is going to be low with bleeding?
Don't know.
Do you mean anemia or do you mean protein?
Sorry, the TP.
No, I thought I'm going to guess not very low.
So the only reason I say that is with acute bleeding, hopefully it would be obvious.
It's not very quick. It takes time
Yeah.
to go down. So you
Yeah.
don't have to see it.
Yeah, so with acute, so absolutely with chronic, you're really likely to have a low TP, like under 50. But with acute blood loss, you might have had equal loss of red blood cells and plasma protein. So you could have a really normal TP to start with. That's going to obviously decrease with time. So absolutely, we're going to look at our total protein. We're going to take a really good history, which sounds really silly, but for chronic blood loss, and we're going to do a really thorough physical exam. We're going to do a rectal, looking for melena. We're going to palpate joints, feeling for any intra-joint bleeds. We're going to do a physical exam. And then Maya, you mentioned biochemistry to look for hyperbilirubinemia. Why else might we want to do a biochemistry in our initial workup? So I think one of the reasons I think for me is one, it would be to rule out, and we'll go through this in more detail, but to rule out like a metabolic cause of an anemia. So in cats, like a hypophosphatemia, cats' red blood cells are really fragile, so they love to hypophosphatemia causes increased red blood cell fragility, and cats are already fragile, so they're more likely to. We're going to help to rule out metabolic causes, and we're also going to screen for other underlying diseases. So we've just said this is down the pathway of regenerative, looking for hemolysis versus hemorrhage. So we're not hopefully going to now suddenly find it's got CKD, because that would cause a non-regenerative, but we could have a trigger for an IMHA, for example, in a cat. And primary IMHA isn't that common in cats. Often they've got something else, an infection, neoplasia. So a biochemistry is really important just to rule out comorbidities. You could have a cat with a raging cholangitis, or triaditis. So it's going to be important just to rule that out. Maya, you mentioned hyperbilirubinemia. Do we always see hyperbilirubinemia with hemolysis?
I don't think so. I think only if it becomes like high enough that the liver can't process it.
Mm-hmm. Yeah, absolutely. So like the acute onset, the onset of disease and how severe it is, and also if they're having quite a lot of intravascular hemolysis, you might get more like hemoglobinemia than bilirubinemia. Do you remember the difference between extravascular and intravascular? Do you want to talk about that at all?
Always confuses me.
Yeah, for sure.
Extravascular is when like it's getting hemolyzed outside the vessel, is how I remember. So like spleen or I think only spleen or maybe marrow, because marrow obviously you have your
Liver, actually, yeah.
liver, yeah.
Yeah.
And
So
intravascular will be in your vascular, like
Yeah.
the blood vessels.
yeah, absolutely. So extravascular, which is I believe the most common, you're going to have, we're speaking specifically about MHA now, we're going to have those red blood cells are going to be marked with an anti-erythrocyte antigen that's flagging to the immune system, hey, this is an abnormal red blood cell, you need to take me out. And the spleen, liver, bone marrow can take those out with extravascular hemolysis. Intravascular is when you've got different parts of the immune system, but often your little membrane attack complexes, which are part of the complement immune system. They're little proteins which combine together and puncture holes in red blood cells and therefore cause the contents to leak out, which is why we can get hemoglobinemia and hemoglobinuria. That doesn't necessarily mean that you're going to have a huge bilirubin spike. That can be quite an aggressive form of IMHA, and there can be overlap, of course, in that patients are doing both at the same time. Those patients might not have high bilirubin, but how would we screen for hemoglobinemia?
Would your MCHC be really high? Is that what you mean?
Not necessarily, like not something necessarily that's going to change the red blood cells themselves, but how we know how they're being destroyed. So as in, like, how do we know that the red blood cell is being punctured in the vascular space?
Like, are you talking about clinical signs? Like you'll have
explaining as well.
You mean like a test, like as in you take your blood and you do your coagulation thing on your slide? Is that what you mean?
Oh, so no, but we'll get there. Or I mean, I'm not explaining myself well. I mean, spin the serum down, because
Yeah.
that will be red. Yeah, and do a urinalysis, because they can often have really really funky urine from hemoglobinuria. Yeah. So in-house, we can do so much initially from CBC, PCV, TP, and spinning the serum, biochemistry, having a look at bilirubin. Say we've excluded or we're less worried about hemorrhage as a cause, and we're more going down the hemolysis route. You mentioned about the in-house test, Julian. So in-house, if we're suspicious of IMHA, we're going to look for markers of hemolysis and markers of immune-mediated destruction. So your markers of hemolysis would be, for example, hyperbilirubinemia or red serum or jaundice serum if you've got hyperbilirubinemia. Would be spherocytes, ghost cells on your smear, particularly in dogs. And then you mentioned one that helps us to look at whether it's immune-mediated destruction. Do you want to elaborate on that in-house test? You don't have to.
Is it Coombs? Is that what it is?
Coombs is the direct antiglobulin test. So that's the one you're going to send externally to the lab.
It's called then, the one that you put a drop on and you see whether your red blood cells are aggregating.
Yeah, perfect. So your saline in-house agglutination. So red blood cells, the agglutinates that we're looking for, they're not actually blood clots. That's not why patients with IMHA are hypercoagulable. That's just because they're in a really severe pro-inflammatory state. The agglutinates that we're looking for are because with IMHA, you've got little antibodies sat on the red blood cell surface. The agglutinates, when two red blood cells come close together, the antibodies can cross-link and join two together. So now you've got these weak bonds between red blood cells bound by these antibodies. They're not actually a clot. So in normal patient systemic circulation, as the blood's flowing, they would get knocked apart all the time. But then when it's static outside of the patient's body, they can clump together and form these little bonds between the antibodies that we'll see as agglutinates. Remember when I said that cats' red blood cells are really fragile? Cats' red blood cells also like to stick together. So you'll see rouleau, those stacks of red blood cell coins you've probably seen pictures of, that they're very, very linear and quite organized, and particularly cats' red blood cells do like to do that. Agglutinates, when you're looking under the microscope at anticoagulated blood, so 1 drop of EDTA and 2 to 4 drops of saline, the agglutinates that you'll see look more chaotic than that, like little random bunches of grapes with no kind of order to them. So it's a nice rule, it's a really nice rule in. Your saline in-house agglutination is really, really specific, meaning if it's there, okay, it's likely to be significant, but it's not very sensitive. You can absolutely have really severe IMHA and not a positive in-house saline agglutination test, in which case that'd be a good patient to send out a Coombs, like you mentioned, Julian, which is actually looking for the anti-erythrocyte antibodies. Yeah. Any questions about saline in-house? Do you guys do them much?
Just so strength. We recommend them all the time. Again, and yeah, just make sure you're looking under the microscope as well as microscopically, because sometimes when there's not that many antibodies, then often when it's you're seeing what's it to say? It's not that many. It's not that many. So it's very important to look under the microscope.
Sure. So we've already got a lot of information in-house from our CBC, biochemistry, PCV-TP, spinning down the serum, looking at a blood smear, maybe doing a serum in-house. Are there any other, when we're starting to think about, if we've got a patient that we are suspicious of IMHA and breaking that into primary, not associated with any underlying disease, and secondary, associative with an underlying disease, does anyone have a bit of a pathway or what they think is reasonable to do? Say we have a 4-year-old male-neutered domestic short hair cat with a PCV of 20 and markers of regenerative anemia and markers of immune-mediated hemolysis. So say we have a positive Coombs test. As I mentioned, cats' primary isn't that common. Does anyone have a kind of pathway in their head about how they like to approach looking for associative causes? Can be anything.
I think starting point, like whether they are FEI, FIV, FELV positive, like you
Absolutely.
take
Yeah.
that into account. I'm not quite sure if that can be the only reason that they tip over and become IMHA, because these cats can be carriers, especially FIV, not FELV so much.
Yeah.
And then
Yeah.
I don't know, as a minimum screening, with what I can do is thoracic rats and possibly an ultrasound of the abdomen is essentially sort
Yeah.
of to start with.
And what would you be looking for?
In the thoracic rads, essentially any sort of evidence of neoplasia or anything like that. It's the
Yeah.
most common sort of thing. In the abdomen, again, any evidence of any disease process that can tip them over.
Absolutely.
Don't necessarily jump into doing like toxo and LCAT and all that. Just not at this like first sort of workup. Start with this first, and then.
I think that's really reasonable. I think the other infectious disease testing is probably going to be quite patient specific. Like if they have other signs that you're suspicious of needing to look for crypto or toxo. The other infectious disease would be Mycoplasma haemophilus. Be a good idea to screen for. You can see those on a smear, but again, it's not a very, there's both false negatives and false positives with doing that. So sending away for a PCR for Mycoplasma haemophilus would always recommend in IMHA, but I agree, the other infectious disease testing you might tailor. And like we just said, really we're screening for anything in the abdomen, a focus, an inflammatory, infectious or neoplastic focus, which in cats, we definitely do see IMHAs where they've got a raging pyelonephritis or a raging cholangitis and pancreatitis or neoplasia, like lymphoma, for example. You mentioned about FELV. FELV, it's definitely reported as a trigger, and we definitely screen for it in IMHA. It does typically cause more of a chronic non-regenerative anemia, but I definitely think it should be in a workup for IMHA, if you guys agree with that.
Helen, how do you know that you've got like what you find is what the initiator was. For example, if you've got a cat that's got like 2 lesions or some like 2 different things, or if you just get one, do you stop there and then not look for anything else?
I love that question. I don't have a good answer to that. I think with that, my approach to that would be to really try and aggressively treat the treatable underlying morbidities. So you could have something which is an incidental finding for sure, but to trigger IMHA, you have to have something which is priming your immune system. So it has to be a big enough stimulus to get some sort of systemic inflammatory response going. For example, like I mentioned, the ones that we probably see are like pancreatitis, cholangitis. So if, for example, I screen ultrasounding a cat and thought it had evidence of cholangitis, we would have to treat the IMHA concurrently, which might be with transfusions, initially might be with immunosuppressive therapy, but that might also be culturing the bile or putting the patient on empirical antibiotics, or even going to a fluoroquinolone if we're really worried about the cat having a really significant bacterial cholangitis. So I would say the underlying things that you find that are treatable, I would try and aggressively treat those while managing the IMHA. The ones that are hard are when you're treating the IMHA and they're not getting better, and you think you might have missed a trigger, or you've got things that you maybe thought were incidental findings, and sometimes you're having to loop back and repeat tests and go back through. But I do think it's a hard call for sure to know if it's, I'd say if you think that something is, and I don't mean an incidental finding like something so boring and benign, but something that it could be causing disease, I would try and treat it.
And I'm not sure if we're going into treatments or whether I can ask a question about treatment now.
Yeah.
If you've got a severe bacterial infection, an IMHA,
Yeah.
how would you proceed in terms of?
If you're worried about the patient getting septic, I would start them on it depends where the infection is and how sick they are and things like that. But if you're so worried about them, they're potentially going to be on intravenous antibiotics. You try and get all your samples for culture if indicated, depending on where the infection is. Start them on infectious disease treatment. So let's assume it's bacterial. Start them on antibiotics aggressively. Stabilize them, which a lot of that is going to be oxygen, transfusions to try and buy them time. If you have a patient that you can transfuse through them being septic, then start immunosuppressive therapy. That would be appropriate. But sometimes it's just going to be a balancing act of at what point is that overwhelming infection going to be under control? We've got antibiotics in the system and we're going to start. So it's probably going to be quite a case by case dependent thing. I'd say that's quite rare to have to worry about, which is good.
Well, the immunosuppression takes quite a while to affect. So
that's a really good point, yeah.
All of the immunosuppressants, it's still going to be 3 days before you really tank their immune system. So I would definitely treat the infection, because you could it's better thing for women those first 24 hours of the infection. And by the time the immunosuppressants kick in, then your infection control. Don't delay it.
At the same time, though, I wonder if, especially for referral hospitals, do you see patients get referred that are not getting better from IMHA, that people have started on steroids that are then have an infection or something that you need to treat?
So there's you'll probably know Richard Malik, either personal or reputation, spreadable infectious disease first. And I've heard him say that he thinks that all immune-mediated diseases are undiagnosed infections. The immune system's responding to something, or something's called deranged immune system. And unfortunately, we can only culture the actual samples of bacteria that exist in the world in labs. So there's a lot of infections, and then there's viruses, and then there's fungal organisms, and there's all everything else. So there's so many infections we're not diagnosing that realistically most of them are self-limiting anyway, and we don't need to necessarily treat them. But if something triggers the immune system, we very rarely find out what it is, but it's probably an infection that we have got. So I think it's not either infection or IMHA, it's often both. And we've kind of just got to really what's causing most morbidity is the immune-mediated reaction. Okay, we have to manage that immune response and then hope that the underlying infection is either responsive to strength. Yeah, really. We better wrap up, actually.
Yeah.
So we say
Thanks, Helen. It was really good.
nailed that.
Yeah, that was helpful. We didn't get very far in anemia. Sorry, I wanted to talk about all the non-rejection.
Anemia is a very big topic.
A very big
Like we
topic.
can spend next week on just not next week, but the next session on non-regenerative anemia, which is a bane of existence sometimes.
It's a bane of existence, which I think is why it's a good topic to cover. Yeah.
Good one. Thank you so much, Helen. Really,
Have a great day.
Thank you.
Thanks
Have a
so
good day,
much.
everyone. Bye.